You know, if you try to describe the human shoulder joint to like an aerospace engineer or structural engineer, they usually look at you like you are completely out of your mind.
Oh, absolutely.
Yeah.
I mean, structurally speaking,
Mhm.
it really is a terrifying design.
Right. They'll look at the blueprints and say, wait, let me get this straight. You want to take a bowling ball, balance it sideways on a golf tee, and then hold it in midair using nothing but a few elastic bands and some shrink wrap.
Yeah, there is virtually no inherent bony stability there at all.
None.
But that lack of stability is, it's an evolutionary trade-off,
Yeah.
right? It's a masterpiece of mobility. I mean, it allows us to reach up to high shelves, reach behind our backs, throw a baseball at 90 miles an hour. It works brilliantly, right up until it doesn't.
Right up until it doesn't. And when it doesn't, when that cartilage completely wears away or those elastic bands finally snap beyond repair,
Right.
we have to go in and essentially rebuild the entire architecture.
Which is exactly what we are getting into today.
Exactly. So welcome to our highly focused exam revision deep dive into shoulder arthroplasty. If you are prepping for your FRCS trauma and orthopedics exams, you have landed in exactly the right place.
And we know how you're probably listening to this, by the way. You are likely driving to work or maybe doing the dishes or trying to get a quick workout in.
Yeah, which means your hands are tied, you can't take notes, you can't draw anatomical diagrams on your steering wheel, and you certainly can't highlight a textbook right now.
No, definitely don't do that while driving.
So we have designed this deep dive specifically to accommodate that audio-only experience. We are going to make sure the high-yield information actually sticks in your brain.
Right, because every single critical anatomical structure, every danger zone, and every exam discriminator is going to be stated twice.
Yes, stated twice.
Yeah.
But we aren't just going to read you a sterile list. We are going to make sure we circle back and really hammer home those exam traps so they get locked into your memory.
We'll do a couple of quick mid-dive reviews to cement the knowledge, and we'll end every major topic with a clear, if you only remember one thing, takeaway.
Exactly. We want the pathophysiology and the anatomy so thoroughly burned into your memory that when you see the stem of a multiple choice question, the correct answer is just glaringly obvious.
So let's establish the narrative frame for today's deep dive. We are going to look at the shoulder replacement through a very specific, almost architectural lens.
I like that. So think of a shoulder arthroplasty as a fortress with two guardians. First, there is the guardian underneath, which is the glenoid foundation. That's the actual bone stock you have to anchor your new implant into.
Right. And second, there's the guardian in front, the subscapularis muscle.
The blast door.
Yeah, the heavy blast door you have to literally cut through just to get inside the joint, and then you have to painstakingly repair it when you're done.
I love that framing. Because from a clinical, and especially from an exam perspective, almost every major complication or failure mode, you will be tested on clusters directly around those two guardians.
They absolutely do. You have to guard the glenoid foundation, and you have to guard the subscapularis.
Yeah.
And, of course, surrounding all of that, you have to respect the rotator cuff
Right.
and the deltoid engine that powers the entire mechanism.
Okay, so before we even make an decision, before we even pick up a scalpel, there is one supreme overriding question that dictates every surgical decision we are about to make. We have an arthritic shoulder. How do we choose the right implant?
Well, the golden rule of shoulder arthroplasty, the absolute first fork in the road, comes down to assessing the soft tissue. Specifically, the question is the rotator cuff intact?
That's a big deciding factor.
It is the only factor that matters first. If the rotator cuff is structurally intact and functioning, you use an anatomic total shoulder arthroplasty.
Okay.
But if the rotator cuff is deficient or irreparably torn, you must use a reverse shoulder arthroplasty. Intact equals anatomic. Deficient equals reverse.
I want to make absolutely sure I have this locked in, and for everyone listening. So, the rule is intact rotator cuff equals anatomic replacement. Deficient rotator cuff equals reverse replacement.
You've got it.
But why? Why does the integrity of those tendons completely change the actual metal and plastic we put into the body?
It comes down to basic biomechanics. The natural shoulder, the anatomic shoulder, relies on what we call a force couple. The rotator cuff muscles compress the humeral head tightly into the glenoid socket.
They hold the golf ball on the tee.
Exactly. They compress it. Once the head is compressed and stabilized, the massive deltoid muscle can fire and actually lift the arm. Without an intact rotator cuff, there is zero compression.
So if you put an anatomic ball and socket into a shoulder with no cuff,
The moment the deltoid fires, it just pulls the humeral head straight up. It slides right off the socket and impinges hard on the acromion above it. So if the cuff is gone, the anatomic design fails instantly.
Wow, okay. Which means we are forced to change the physics entirely, which we will get into later with the reverse design. But let's start down that first path. We are assuming we have a healthy cuff.
Right.
So, a patient comes into your clinic with bone-on-bone glenohumeral osteoarthritis, but their rotator cuff is firing beautifully.
In that scenario, we are cleared to perform an anatomic total shoulder arthroplasty, often abbreviated on the exam to anatomic TSA.
Okay.
The goal here is exactly what the name implies. We are recreating the natural anatomy of the patient as closely as mechanically possible.
We are essentially giving them back the biological ball and socket they were born with. We are just substituting the worn-out cartilage with a cobalt chrome sphere and a polyethylene cup.
Precisely.
Okay.
But recreating the anatomy isn't just about sticking a ball on a stick. You have to match the natural torsion and the twist of the human skeleton.
Right.
And for the FRCS exam, you need to know the specific numbers for the humerus. Humeral head retroversion averages 20 to 30 degrees.
Let me echo that critical number for the listeners. The average humeral head retroversion is 20 to 30 degrees.
That's right.
Now, what does retroversion actually mean in this specific context?
Well, if you look straight down the shaft of the humerus from the top, like a bird's eye view, the articular surface of the ball doesn't point straight inward at the rib cage. It's twisted backward.
Okay, twisted backward relative to what?
Retroverted relative to the elbow joint below it. Historically, the textbooks and exam answers have always stated 20 to 30 degrees of retroversion. However, keep in mind that recent 3D CT mapping studies of human anatomy are showing that the true average is leaning much closer to 20 degrees.
Good to know. So we make our bony cuts, we match the 20 to 30 degrees of retroversion, and we cement our plastic socket into place. We have an intact rotator cuff compressing the joint. It sounds like a perfect architectural restoration.
On paper, yes.
So what goes wrong? I mean, if I think about this like building a house, if you build a beautiful new structure on a foundation that is slipping or crumbling, the whole house is going to crack.
That is the perfect analogy for the most devastating long-term problem we face.
Okay.
And it leads us directly into the ultimate exam trap for this procedure.
Okay, hit me.
The absolute #1 complication and the leading cause of revision surgery for an anatomic TSA, representing roughly a third of all primary osteoarthritis revisions, is glenoid component loosening.
I am going to repeat that because you said it is guaranteed to show up. The most common complication and leading cause of revision for an anatomic TSA is glenoid component loosening.
Examiners love to test this. The question stem will describe a patient 5 or 10 years out from an anatomic TSA who is now experiencing this deep, dull, aching pain.
Okay.
And they will give you a list of potential complications, like is it a late onset infection? Is it anterior instability? Is it a new rotator cuff tear? But statistically, glenoid loosening is the king. The plastic socket literally debonds from the bone and starts rocking back and forth.
So what actually predicts this? I mean, we use high-quality bone cement. We prepare the bone bed. What drives that plastic socket to wobble loose from the scapula?
The primary predictor of failure is glenoid morphology.
Glenoid morphology, meaning the physical shape of the bone before we even started the operation?
Exactly. The preoperative shape of the arthritic bone dictates your failure rate. And the exam will want you to know the specific, highly tested morphological classification that causes the absolute most trouble for surgeons.
What's it called?
It is the Walch B2 glenoid.
Second time on that name for everyone on the commute. The high-risk morphological shape is the Walch B2 glenoid. Walk us through what a Walch B2 actually looks like in 3 dimensions. What is the actual pathology here?
Well, to understand a B2, you have to understand the natural history of shoulder arthritis. Often, as the joint wears out, the patient loses internal rotation and the posterior capsule gets incredibly tight.
Okay.
This tightness acts like a physical bumper, pushing the humeral head backward. So over years, the humeral head rides backward and constantly grinds away the back half of the glenoid socket.
Oh, wow. It's like a mortar and pestle where you are only grinding on one specific side.
Exactly. So what does a Walch B2 look like? It is defined as biconcave, posteriorly worn, and retroverted.
Wait, biconcave, meaning there are 2 separate dishes worn into the bone.
Yeah, exactly like that. Because the humeral head has been riding backward, it wears a brand new secondary dish into the back of the bone. So instead of one smooth concavity, you have 2. It is biconcave.
Oh, I see.
And because it has eroded all that posterior bone stock, the entire angle of the socket is now retroverted, pointing backward. It often presents with posterior humeral head subluxation, where the ball is actually resting in that newly worn posterior dish.
So the foundation isn't just slipping, it's literally been excavated. The ball keeps sliding backward into that second concavity, and if you try to stick a flat, standard plastic cup onto a bone that has two different levels, it's just not going to sit flush.
It won't. It'll wobble. And this is where the exam trap comes in. The question stem might try to lure you into guessing that the patient's age is a primary risk factor for loosening, or perhaps they will blame the use of a stemless humeral head implant.
They try to distract you.
Right. You have to ignore those distractors. The primary driver of early loosening is strictly the shape of the glenoid bone stock. It is the biconcave retroverted Walch B2 morphology.
So as the surgeon, you're staring at the pre-op CT scan. You see this biconcave, posteriorly worn out socket. Cementing a standard plastic cup onto that defect is going to result in the rocking horse phenomenon, where it wobbles and eventually fails.
Yeah.
What are our surgical solutions? How do we actually fix the foundation?
You have a few options in your armamentarium, each with its own trade-off. The most common traditional method is eccentric reaming to correct the version.
Eccentric reaming.
It means you take your powered hemispherical reamer and you intentionally grind away the high side of the bone, which is the anterior front half of the glenoid, to make it level with the worn-down posterior side. You are basically trying to create one single flat surface again.
Hold on, I can see the mechanical catch there. If the back is already worn away and now you are grinding away the front just to make it level, aren't you eating away a massive amount of the patient's remaining bone?
A massive amount. That is the critical limitation. The glenoid isn't a deep block of bone. It's a very shallow vault.
Right.
If you over-ream, you are medializing the joint line. You are pushing the entire joint deeper toward the center of the body. Worse, you are grinding right through the hard subchondral bone and getting into the soft, spongy cancellous bone.
Oh, that sounds bad for the cement.
It is. So you compromise your bone stock, leaving you with poor, soft bone for the pegs of your plastic glenoid to cement into.
Yeah.
You successfully trade version correction for catastrophic loss of fixation.
So by fixing the angle, you completely ruin your anchor points. What if eccentric reaming isn't enough? Or if it would medialize the joint way too much? What else can we do?
Well, if reaming will take too much bone, you have to build up the back instead of grinding down the front. You can use structural bone grafts, literally taking a piece of the humeral head you just cut off and screwing it into the posterior defect.
Reusing their own bone, basically.
Yeah, or increasingly we use specific metal augments. These are titanium base plates that are physically thicker on one side, called wedge augments or step augments, to fill that gap.
And what if the bone is just completely gone, like a severe Walch B3 or an incredibly deep B2 where there's virtually no vault left to anchor any of this into?
If the glenoid is so badly worn that it simply cannot be safely resurfaced with a plastic component, you must abandon the anatomic TSA plan entirely. You switch to a reverse shoulder replacement.
Wait, really? Even if the rotator cuff is perfectly fine?
Even with a perfectly intact cuff. Because the reverse base plate uses a long central peg and locking screws that can gain purchase deep in the scapula, bypassing the surface defect entirely.
That is a phenomenal pivot. Even with a good cuff, terrible bone stock might force your hand into a reverse just for the screw fixation alone. Okay, time for the golden rule of this first guardian. If you only remember one thing for this section, the commonest complication after anatomic TSA is glenoid loosening. And the biggest risk factor driving that loosening is the biconcave, retroverted Walch B2 glenoid morphology.
Perfect. So let's move from the bone underneath to the soft tissue in front. The second guardian, the subscapularis.
We've sorted out the foundation. Now we really have to talk about the heavy blast door we have to break through just to get there. Why does the subscapularis completely dominate the surgeon's mind during the early rehabilitation phase?
Because of the surgical approach itself. When you perform the standard delta pectoral approach for a shoulder replacement, you are coming in through the front of the joint. You retract the deltoid laterally and the pectoralis major medially, and right there, staring you in the face, completely blocking your view of the joint capsule, is the massive subscapularis muscle.
It's just in the way.
It is entirely in the way. To get a new joint inside, you have to take the subscapularis down, and more importantly, you have to successfully repair it when you're done.
And taking it down isn't just one standard, universally agreed upon move, is it? I mean, surgeons debate this constantly.
Oh, they argue about it all the time. And the exam expects you to know the 3 accepted methods for taking it down. First, you can do a standard tenotomy, where you take your scalpel and cut straight through the tendon itself, leaving a little stump on the bone to sew back to.
Okay, that's one.
Second, you can do a peel, where you use electrocautery to strip the tendon directly off its footprint on the lesser tuberosity. Or third, you can do a lesser tuberosity osteotomy, an LTO.
Let's pause on the LTO for a second. That means you aren't actually cutting the tendon at all, right? You are taking a saw or an osteotome and cutting off the small piece of bone that the tendon attaches to.
Exactly right. You crack off a wafer of bone with the tendon still perfectly attached to it. The massive biological advantage here is that when you repair it at the end of the case using heavy sutures, you are bringing bone to bone.
Which heals better.
Much better. Bone heals to bone much faster and much more reliably than tendon heals to tendon.
Right. But whichever method you use, tenotomy, peel, or LTO, you are relying on heavy sutures to hold it together at the end of the procedure. And that repair dictates everything the patient is allowed to do for the next 6 weeks.
Yes, it governs the whole rehab protocol.
But let's look at the failure mode. What happens if that repair fails? Say the patient falls or they lift something way too heavy and those sutures rip. What are the clinical consequences?
If the subscapularis repair fails, you lose the entire front half of the shoulder's force couple. The subscapularis is the front tether. If it snaps, this leads directly to anterior instability or anterior subluxation of the new joint.
Stating that a second time for the listeners to lock it in. Subscapularis failure leads directly to anterior instability or subluxation.
Right.
The ball literally falls out the front of the socket. You can actually see this on a post-op axillary radiograph, right?
Yeah, the metal head starts drifting anteriorly relative to the plastic cup. It's a very clear radiographic sign. The posterior rotator cuff is still pulling from the back, but there is absolutely nothing opposing it in the front. So the humeral head just pushes forward.
Wow.
For exam purposes, if you get a classic late complication question that says a patient presents with anterior subluxation after an anatomic PSA, your brain should immediately translate that phrase to subscapularis failure.
Let's bring this out of the x-ray room and into the physical clinic. The patient is sitting on the exam table 3 months post-op. How does this structural failure actually show up clinically during your physical examination?
The most obvious glaring sign is increased passive external rotation compared to the other arm.
Because the front tether, the seatbelt, basically is gone.
Precisely. Normally, the subscapularis acts as the check rein across the front of the joint. It severely limits how far outward you can rotate the arm. If that tendon tears off the bone, that arm can suddenly rotate externally much, much further than the contralateral side. It will just flop outward.
That makes sense.
Furthermore, you will see positive signs on your specific subscapularis muscle tests. The liftoff test, the belly press test, and the bear hug test will all be profoundly positive for weakness or complete failure.
Just to quickly visualize those for the listeners, the belly press test is when the patient places their hand on their stomach and tries to push inward without dropping their elbow backward.
Right.
If the subscapularis is gone, they can't generate that internal rotation force, so they cheat by dropping their elbow behind their body to use their shoulder capsule to push instead.
Exactly. They recruit other muscles because the primary internal rotator is totally detached. And this profound risk of failure perfectly explains our strict rehab protocols.
The 6 weeks of restrictions.
Postoperatively, we restrict passive external rotation, usually no more than 30 degrees, to prevent stretching the repair. And we completely block active internal rotation for roughly 6 weeks. We don't want them actively firing the muscle, pulling against those tiny sutures.
We are essentially buying time for biology to heal what we cut. All right, let's pivot to a highly tested anatomy point right here. The FRCS loves to test neuroanatomy. What nerve, or nerves, supply the subscapularis muscle?
The upper and lower subscapular nerves supply it. But knowing the name of the nerves isn't enough. The real exam trap is knowing where those nerves originate in the brachial plexus.
Okay, where do they originate?
They originate from the posterior cord of the brachial plexus.
Listeners, engrave this in your mind right now. The upper and lower subscapular nerves originate from the posterior cord of the brachial plexus. Why is this such a favorite trap for examiners?
Because it feels totally counterintuitive if you just look at a gross anatomy textbook. The subscapularis sits on the anterior face of the scapula. It is fundamentally a front-facing muscle situated deep in the front of the chest against the ribs.
So, candidates taking a multiple-choice test logically but incorrectly guess that an anterior muscle must be supplied by the lateral or medial cord.
Right, but it's the anterior muscle supplied by the posterior cord.
I like to think about it as the anterior-posterior paradox. The muscle in the front gets its electrical wiring from the back. Anterior muscle, posterior cord. It actually comes down to embryology, doesn't it? How the limb bud rotates during fetal development, dragging the nerve supply with it. So do not get tricked into guessing the lateral cord.
That embryological rotation is exactly why it happens, and the anterior-posterior paradox is a great mental hook to remember it. So, what is our final takeaway for this second guardian?
If you only remember one thing for this section, subscapularis failure causes anterior instability and increased passive external rotation, and the muscle is supplied by the posterior cord of the brachial plexus.
Excellent. Now that we've discussed cutting the subscapularis, we really need to talk about what surrounds it. Let's move into danger anatomy and the approach.
We are already knee-deep in discussing the deltopectoral approach. We know we are going between the deltoid and the pec major. But you aren't just cutting blindly. You are navigating an absolute minefield of vasculature and nerves just to reach the joint. You're the surgeon. You're making the skin incision. What is our first superficial anatomical landmark?
Your superficial starting point, your biological roadmap, is the cephalic vein. It runs right in the deltopectoral groove. Finding that blue vessel shows you the exact interval between the deltoid muscle and the pectoralis major.
Okay, we found the cephalic vein, we're retracting the muscles, and we're going deeper. The exam is going to test 3 specific high-risk danger structures in this deep field. Let's take them one by one. And since this is the danger zone, we're definitely repeating each one twice. Structure number 1.
Danger structure number 1 is the arcuate artery.
Let me lock that in. Danger structure 1, the arcuate artery.
It is the terminal ascending branch of the anterior humeral circumflex artery. It runs straight up the bicipital groove alongside the long head of the biceps tendon, and it is the main intraosseous blood supply to the humeral head itself.
And the second time, the arcuate artery, which is the terminal branch of the anterior humeral circumflex. Where exactly are we at risk of hitting the arcuate artery during the operation?
You risk lacerating it when you elevate the long head of the biceps tendon out of its bony groove. Surgeons often tendinize or release the biceps during a shoulder replacement because it's a huge source of pain.
Wait, because we take the biceps down for pain relief, right?
Yeah, you tendinize it, but the artery is sitting right next to it in that groove. If you are clumsy with your scissors or your elevator when lifting the biceps tendon, you will tear that artery, and it is a high-pressure vessel that retracts and bleeds heavily into the field.
So manipulating the biceps tendon risks the arcuate artery. Got it. Danger structure number 2.
Number 2 is the axillary nerve.
Repeating that, the axillary nerve. This is the big one. This supplies the deltoid. If you cut this, the patient essentially loses the ability to lift their arm forever. Where is it hiding, and how do we protect it?
It courses from front to back, exiting the axilla through the quadrilateral space, and it tucks just underneath the glenohumeral joint and the inferior capsule. Your surgical landmark to protect it is the inferior border of the subscapularis muscle.
The inferior border of the subscapularis.
Right. If you trace the bottom edge of the subscapularis down with your finger, you will literally feel the axillary nerve crossing right below it. We often place a specific retractor there just to guard it.
So what surgical step puts it most critically at risk?
It is an extreme danger during the inferior capsule release. To mobilize the arthritic stiff joint so you can actually see the glenoid, you have to cut the tight capsule at the bottom of the joint. But the axillary nerve is sitting right on the other side of that capsule, passing roughly 10 to 25 millimeters below the inferior glenoid rim.
Hold on. 10 to 25 millimeters. That is basically a centimeter. We were using heavy scissors to cut thick, scarred tissue, and the main nerve powering the entire shoulder is 1 centimeter away.
Exactly. It's incredibly close. If you plunge your scissors or point your electrocautery too deeply downward during that inferior release, you will absolutely damage the axillary nerve.
Okay, so we find the inferior border of the subscapularis to protect the axillary nerve. Danger structure number 3.
Number 3 is the musculocutaneous nerve.
Structure 3, echoed, the musculocutaneous nerve. Where does this one run?
It originates from the lateral cord, and it enters the coracobrachialis muscle remarkably high up in the arm, often as close as 3 to 5 centimeters distal to the coracoid process.
Now, what is the actual mechanism of injury for the musculocutaneous nerve? Because we aren't usually cutting with a scalpel anywhere near the coracoid process, are we?
No, it's rarely a sharp transection. It is almost always a traction injury.
Traction, like stretching it.
Yes. To see deep into the joint socket, the surgical assistant has to pull really hard on retractors placed against the strap muscles. This is the conjoint tendon consisting of the short head of the biceps and the coracobrachialis coming off the coracoid. If you use aggressive, prolonged strap muscle retraction, You physically stretch the musculocutaneous nerve where it enters the muscle belly.
And how would the patient present in the recovery room if we stretch that nerve way too hard?
They will wake up with profound weakness in elbow flexion and forearm supination because the musculocutaneous nerve supplies the biceps brachii and brachialis muscles. The exam will give you a clinical scenario, something like a patient undergoes an anatomic TSA and post-operatively is unable to bend their elbow against resistance.
Oh, and they want you to link it back.
Exactly. They want you to logically link that elbow flexion deficit back to aggressive strap muscle retraction, stretching the musculocutaneous nerve during the exposure.
That makes perfect sense. Okay, so that covers the major blood vessels and nerves. What about the rotator cuff itself? If we are doing an anatomic replacement, we have an intact, healthy rotator cuff. Is there any step during the bony cuts that puts that healthy cuff at risk?
Absolutely. The primary danger to the cuff is during the humeral neck cut. When you take the oscillating saw to cut off the arthritic humeral head, if your cut is too distal, meaning you start the saw too far down the shaft of the humerus, or if you angle the saw in excessive retroversion, you can actually amputate the rotator cuff insertion right off the greater tuberosity.
So you start the case with a perfectly intact cuff, and through poor surgical technique, you accidentally create a massive, irreparable rotator cuff tear with your saw. You essentially turn an anatomic shoulder into a cuff-deficient shoulder on the table.
Exactly. The cut must be meticulously planned, often using an anatomical cutting guide, to ensure the saw blade stays proximal to the insertions of both the supraspinatus on the greater tuberosity and the subscapularis on the lesser tuberosity.
Time for our takeaway. If you only remember one thing for this danger anatomy section, watch out for the arcuate artery when lifting the biceps, find the axillary nerve at the inferior subscapularis border to protect it during capsular release, and avoid aggressive strap muscle retraction to save the musculocutaneous nerve.
Which brings us perfectly to our first major checkpoint.
Let's take a quick pit stop to consolidate. We've thrown a ton of anatomy at you. Here is the fast-paced summary of the first half of this deep dive. Anatomic TSA is strictly indicated for glenohumeral osteoarthritis with an intact, functioning rotator cuff. We recreate the anatomy, dialing in a humeral retroversion of about 20 to 30 degrees.
Right.
The absolute #1 complication and cause of revision is glenoid component loosening. And the primary driver for that loosening is the Walch B2 morphology, that is the biconcave, posteriorly worn retroverted socket with posterior subluxation. The subscapularis taking it down via tenotomy, peel, or LTO is required for the delta pectoral approach. If your repair fails, the forescapula is lost, resulting in anterior instability and a massive increase in passive external rotation. And remember, the embryological paradox, the anterior subscapularis, is innervated by the upper and lower subscapular nerves, which originate from the posterior cord.
Yes.
Danger anatomy 3 structures to guard. The arcuate artery bleeds when elevating the biceps. The axillary nerve is at extreme risk during the inferior capsular release, so find the inferior border of the subscap to protect it. And the musculocutaneous nerve gets a traction injury with aggressive strap muscle retraction, leading to a loss of elbow flexion.
That is an immense amount of high-yield information, beautifully compressed. Now, I need everyone listening to clear their mental whiteboards because we are going to flip the entire mechanical system upside down.
Literally. Let's move to reverse total shoulder arthroplasty, biomechanics, and indications. We've mastered the intact cuff. Let's pivot back to that initial deciding question. What do we do when the rotator cuff is irreparably torn? We have no compression, no force couple. The anatomic implant will just dislocate upwards.
Right. When the cuff is gone, we shift to the reverse TSA. The core classic indication for this procedure is rotator cuff tear arthropathy. The classic exam presentation will describe an elderly patient, often in their late 70s or 80s.
Okay.
They have a massive, chronic, irreparable rotator cuff tear. Because the cuff is gone, they have lost the compressive force couple, so the humeral head undergoes superior migration. It rides high up, out of the socket, and physically grinds against the undersurface of the acromion. They have severely painful arthritis, and critically, they present with pseudoparalysis.
Let's define pseudoparalysis for the listeners. It implies paralysis, but it isn't neurological, right? Meaning the axillary nerve is fine, the deltoid muscle is actively trying to fire, but they physically cannot lift their arm above horizontal.
Correct. It is a mechanical failure, not a neurological one. The deltoid contracts, but because there is no stable fulcrum, because the cuff isn't holding the ball in the socket, the deltoid just pulls the humerus straight up into the acromion instead of pivoting it outward in elevation.
Ah, I see.
So a 75-year-old with a painful arthritic shoulder, a high-riding humeral head, and an arm they mechanically cannot lift. The undisputed answer is a reverse TSA.
I know you mentioned elderly there. Just for clinical context, what if this exact same presentation, massive tear, pseudoparalysis, shows up in a 45-year-old heavy laborer?
Well, that is a much harder clinical conundrum because a reverse shoulder relies heavily on the deltoid, and a heavy laborer will wear out the plastic liner of a reverse very quickly. Surgeons debate muscle transfers, superior capsular reconstructions, or hemiarthroplasty. But for the FRCS exam, do not overthink it. Look for the elderly patient with pseudoparalysis and choose the reverse.
So we have a dead motor. The rotator cuff is completely gone. Here is the engineering brilliance of Paul Grament, who invented the modern reverse. How does simply flipping the ball and socket fix a shoulder with no rotator cuff?
It is a stroke of mechanical genius. By placing the metal ball, the glenosphere, on the patient's scapula and putting the concave plastic cup on the humerus, the reverse implant radically changes the shoulder's kinematics in two critical ways.
And what are they?
It medializes and distalizes the center of rotation.
I'm stating that a second time because if you understand this phrase, you understand the entire surgery. The reverse implant works because it medializes and distalizes the center of rotation. Let's break that down with an analogy. I always think of this mechanism like a playground seesaw.
A seesaw is a perfect lever system to visualize this, yeah.
Right. Imagine a seesaw where the fulcrum, the pivot point, is dead in the middle. On one side, you have a very heavy adult that represents the weight of the human arm. On the other side, you have a small child trying to lift them. That represents the deltoid muscle trying to work all by itself without the help of the rotator cuff.
Right. They can't do it.
The small child cannot generate enough force. The arm stills down. But if we pick up that fulcrum and move it much closer to the heavy adult and further away from the child, what happens? We instantly give the child a massive mechanical advantage.
Exactly. By medializing the center of rotation, moving the pivot point closer to the center of the body, closer to the glenoid bone, we dramatically increase the lever arm of the deltoid muscle. The deltoid now has a mechanical advantage to lift the heavy arm. And by distalizing it, moving the pivot point physically further down, we stretch and tension the deltoid muscle fibers. We literally tighten the spring.
So we've shifted the fulcrum to give the deltoid leverage, and we've tensioned the deltoid to give it more power.
Yes. The deltoid becomes the sole, incredibly efficient engine for forward elevation. The reverse relies entirely on the deltoid, completely bypassing the need for a functioning rotator cuff.
That's amazing.
Furthermore, because that new center of rotation is a fixed, stable metal sphere bolted to the scapula, the deltoid has a solid, unmoving fulcrum to pull against. The plastic cup pushes up against the metal ball, which completely prevents that superior migration we talked about earlier. The head is locked down underneath the ball, and the deltoid just lifts the arm up.
It really is a masterpiece of biomechanical engineering. It solves the lack of compression by creating a fixed mechanical stop.
It absolutely is. Grament's design changed the world of shoulder surgery.
Takeaway time. If you only remember one thing for this biomechanics section, the reverse TSA is for the cuff-deficient arthropathic elderly shoulder, and it works by medializing and distalizing the center of rotation so the deltoid has the mechanical advantage to power elevation.
But as with any engineering marvel, every brilliant mechanical solution introduces a new, specific vulnerability.
Which brings us to the next section, reverse TSA complications. What is the Achilles heel of this medialized design?
The signature complication of the reverse shoulder, the unique failure mode they will test you on without fail, is scapular notching.
Listeners, engrave this term, scapular notching. What exactly is the mechanism of notching?
Remember how Grament's design moved the center of rotation medial and distal? We shove the entire humerus much closer to the scapula to give the deltoid a mechanical advantage.
Right.
This phenomenon is sometimes called the Surte effect. Because of that tight new geometry, when the patient brings their arm down to their side, when they adduct the arm, the medial edge of the plastic humeral cup physically hits the bone of the inferior scapular neck. It impinges. And over thousands of cycles of adduction, as it rubs against the bone, the hard plastic acts like a saw, mechanically eroding the pillar of the scapula.
So adduction causes the plastic cup to literally chew a notch into the pillar of the scapula below the socket. That sounds terrible. It must generate a massive amount of plastic or debris inside the joint.
It does. It generates polyethylene wear particles, which leads to macrophage activation, osteolysis, and eventually catastrophic baseplate loosening. So we absolutely have to prevent it.
How do we fix it? Or better yet, how do we prevent it while we are in the operating room placing the implants?
The exam wants you to know the specific surgical technique to prevent it. To minimize scapular notching, the surgeon must position the glenoid base plate inferiorly with an inferior tilt.
Second time on the fix for the commute. To prevent notching, position the base plate inferiorly with an inferior tilt. How does that stop the impingement?
Think about it geometrically. If you slide the metal base plate as far down the face of the glenoid as possible, overhanging the inferior rim slightly, and you tilt the entire sphere slightly downward, you create physical clearance below the sphere. You're dropping the pivot point down.
Ah, I see.
So when the arm comes down into adduction, the plastic cup clears the scapular bone entirely instead of grinding into it.
So superior positioning, or aiming the tilt upwards, is the absolute enemy here.
Yes. Superior positioning will guarantee early and severe scapular notching. Modern implant designs also use a lateralized glenosphere, pushing the ball slightly outward to help the arm clear the bone. But the fundamental surgical positioning rule remains. Inferior base plate, inferior tilt.
Got it. Now, what about while we were actually in the operating room doing the reverse? We talked about notching as a late complication. Is there a specific intraoperative pitfall examiners like to ask about?
Yes, iatrogenic humeral shaft fracture. And specifically, the exam wants to know when and how it most commonly happens. It is most likely to happen during reaming of the humeral canal.
How does reaming cause a fracture? We're just hollowing out the marrow space.
It's usually a physical mismatch between the surgeon, the power tool, and the surgical assistant.
How so?
Well, the assistant is standing across the table, holding the patient's arm securely to present the humerus to the surgeon. The surgeon is running a high-speed, powered reamer down the hollow shaft of the bone. If that reamer meets hard cortical bone and catches, the rotational torque generated by the motor is immense.
And if the assistant is holding the arm in a death grip?
Exactly. If the assistant is gripping the arm too tightly, refusing to let the arm move, that rotational torque has nowhere to go but through the bone itself. The energy spirals down the shaft and cracks it like a dry branch.
So the assistant's death grip causes a spiral fracture.
Yes. The surgical teaching and the answer to the concept on the exam is that the assistant must hold the arm loosely during powered reaming. If the reamer catches, the assistant lets the whole arm spin slightly with the reamer, dissipating the torque safely into the air rather than into the humerus.
Incredible detail. Okay, now I want to ask about a fake complication. The exam trap you alluded to earlier. Examiners love to throw in distractor answers that sound plausible to a stressed candidate. What's the trap complication for the reverse?
The trap complication they will list is supraspinatus dysfunction.
Second time. Supraspinatus dysfunction is a fake complication. Why is that a trick?
Think back to our core indication. Why did we choose the reverse in the first place? We use a reverse TSA precisely because the rotator cuff, including the supraspinatus, is already massively and irreparably torn. The supraspinatus is already dead and non-functioning.
Oh, right.
The reverse implant is mechanically designed to work completely without it, relying solely on the deltoid. Therefore, a lack of supraspinatus function cannot possibly be considered a cause of failure for a reverse implant. It's a trick question designed to see if you understand the core philosophy of the implant.
It's like saying your brand new electric car broke down on the highway because it ran out of gasoline. It doesn't use gasoline, it doesn't use the supraspinatus.
Exactly. Real failure causes for the reverse include glenoid base plate loosening, scapular notching, poor bone stock, axillary nerve dysfunction, because you absolutely need the deltoid to work, instability, and infection, but never the supraspinatus.
Excellent. If you only remember one thing for this complications section, scapular notching is the reverse's signature complication, minimized by an inferior base plate with inferior tilt. And supraspinatus dysfunction is a trap answer, not a failure mode.
And that cues our second major checkpoint.
Let's do a brisk summary of the reverse TSA to lock it all down before the final stretch. Indications. We use it for the cuff-deficient arthropathic shoulder, typically an elderly patient presenting with severe pain and pseudoparalysis. Biomechanics. It works by medializing and distalizing the center of rotation, which turns the deltoid into a superpowered lever and completely prevents superior migration of the humerus.
Exactly.
Complications. The signature long-term issue is scapular notching, which is fixed surgically by placing an inferior base plate with an inferior tilt. Intraoperatively, watch out for humeral shaft spiral fractures during reaming due to excess torque and a tight grip. And remember, supraspinatus dysfunction is the trap answer. It is not a mechanism of failure.
Perfect. We are on the home stretch now. This final section covers contraindications, positioning, infection, and general pathology. This is the final sprint of loose ends, the critical standalone concepts that examiners absolutely love to pepper into the multiple choice section.
Let's start with strict contraindications. If a patient comes into your clinic, their shoulder is destroyed, they are in agony, when do you look at them and say, absolutely not, we cannot do a shoulder replacement under any circumstances?
A true strict contraindication for any shoulder arthroplasty is a preganglionic brachial plexus injury.
Stating that twice to ensure it lands. A true contraindication is a preganglionic brachial plexus injury. What does preganglionic actually mean in practical anatomical terms?
The brachial plexus roots emerge from the spinal cord. Preganglionic mean the root avulsion. The nerve roots have literally been torn directly out of the substance of the spinal cord itself, proximal to the dorsal root ganglion. When this happens, the patient has a flail insensate arm. The muscles are completely paralyzed, and because the central nervous system tissue is torn, the prognosis for spontaneous or surgical motor recovery is virtually zero.
Because if the nerves are severed further down the arm, postganglionic, sometimes you can do nerve transfers or grafts to bring them back. But preganglionic, right off the spinal cord, it's game over for those muscles.
Exactly. And because a shoulder replacement, whether it is anatomic or reverse, requires some functioning muscle to move it and stabilize it, usually the deltoid in reverse, putting a new metal and plastic joint into a completely flail arm is entirely pointless. Without muscle tone to hold the components together, the heavy weight of the arm will just cause it to instantly dislocate. So it is strictly contraindicated.
What are the trap answers? The exam will list things that sound like reasons to cancel surgery, but actually aren't.
They will offer you options like limited passive external rotation, posterior glenoid erosion, irreparable supraspinatus tear, or active inflammatory arthritis. None of these are strict contraindications. In fact, inflammatory arthritis, like severe rheumatoid arthritis, is actually a very common indication for performing a shoulder replacement. Don't let them trick you into denying surgery to a rheumatoid patient.
Let's talk about positioning the humeral head during surgery. We talked extensively about base plate position for the reverse to avoid notching. But what about the height of the humeral component itself on the shaft? What happens if you cement the stem in at the wrong height?
It's a Goldilocks situation. You have to get it just right. If you position the humeral head too superiorly, meaning you leave the stem sitting too high out of the bone, you put excessive tension on the remaining soft tissues, and the metal head will physically impinge against the acromion roof above it.
So too high hits the roof.
Right. And if you position it too inferiorly, maybe you sink the stem too deeply into the shaft, you run into lateral abutment of the greater tuberosity against the acromion when the patient tries to lift the arm, or you cause internal impingement of the components against the inferior glenoid rim.
But there is a very specific, highly tested exam trap related to height, specifically occurring after a hemiarthroplasty for a trauma fracture. Walk us through that.
Yes, this is a classic FRCS scenario. A patient sustains a complex comminuted proximal humerus fracture, maybe a 4-part fracture. The bone is in pieces. You go in to do a trauma hemiarthroplasty where you are just replacing the ball on a metal stem and trying to tie the fractured tuberosities around it.
Right.
If, while preparing the bone, you resect too much of the shattered proximal humerus, you will sink the metal stem far too deep into the humeral canal. This surgical error results in humeral shortening.
Second time on this crucial concept. Taking too much proximal bone during a fracture case results in humeral shortening. Why is shortening the humerus by a centimeter or two so devastating to the patient's recovery?
Because of the effect on the deltoid muscle. The deltoid attaches to the acromion at the top and the deltoid tuberosity on the humerus shaft at the bottom. If you shorten the humerus, the distance between the acromion and the deltoid tuberosity has been physically shortened. The deltoid muscle suddenly becomes completely slack. The spring has lost all of its resting tension.
And a slack muscle can't generate force.
Exactly. The slack deltoid cannot pull. Furthermore, this lack of resting tension causes profound inferior instability. Without the deltoid holding it up, the heavy arm literally sags downward, subluxating inferiorly. The clinical presentation in the exam stem will be a patient who had a hemiarthroplasty for a fracture a few months ago, and now they present to clinic unable to actively elevate their arm past horizontal, with the x-ray showing inferior subluxation.
So if the stem says profound difficulty elevating after trauma hemiarthroplasty, your brain immediately jumps to the surgeon causing humeral shortening, which made the deltoid slack.
You got it perfectly. It's a tensioning failure.
Let's pivot to the topic of infection. Every major joint in the body has its nemesis bug. The knee and hip fight against Staph aureus and Staph epidermidis. What is the shoulder's special, unique nemesis?
The bacterial organism that absolutely loves the shoulder environment is Cutibacterium acnes.
Second time on the name. Cutibacterium acnes. And for the senior surgeons or those who learned it under the old nomenclature, this used to be called Propionibacterium
Right,
acnes.
it's the same bug, just a new taxonomy. And C. acnes has some very distinct, highly testable characteristics that make it a nightmare for shoulder surgeons. First and foremost, it is an indolent organism.
Indolent meaning lazy, slow-growing, quiet.
Exactly. It doesn't cause a massive, roaring inflammatory response. Patients with a C. acnes paraprosthetic infection usually will not present with a high fever. They won't have a hot, red, angry, erythematous joint. They might not even have severe pain. They just present with a stiff shoulder or early implant loosening on X-ray that we can't quite explain mechanically. It's a very common cause of quiet, stealthy implant failure.
What makes the shoulder so special? Why does C. acnes love this joint and not the knee? And who is most at risk?
Well, C. acnes is an anaerobic bacterium that naturally colonizes the sebaceous glands of the human skin, the glands that produce oil. The skin of the shoulder and the upper back has a massively higher concentration of sebaceous glands than the hip or the knee. And specifically, because of hormonal differences in sebum production, men carry a significantly higher bacterial burden of C. acnes on their shoulders than women do.
So a male patient is naturally at a higher risk of carrying a heavy load of this bacteria right into the incision. But the most important exam fact about C. acnes isn't just that it's indolent, it's how we actually catch it in the microbiology lab.
This is the critical clinical pitfall. Because C. acnes is so incredibly slow-growing and anaerobic, the standard 3 to 5 day culture used in most hospitals will often come back completely negative. It will fool the surgeon into thinking the joint is sterile. The critical clinical rule, and the guaranteed exam answer, is that if you suspect a shoulder infection, you must hold the lab cultures for 14 days.
I am repeating that loudly because it is so vital. You must instruct the lab to hold cultures for 14 days to catch Cutibacterium acnes.
If you don't hold them for 14 days, you will miss the infection. The patient will get a new implant put into an infected bed, and it will fail all over again. Now, for the exam, you need to contrast that quiet, indolent picture of C. acnes with an acute post-operative infection.
Right, a totally different clinical picture. The patient is 4 days out from surgery. The surgical incision is actively draining pus. They have a systemic fever of 39 degrees, and the preliminary lab gram stain shows gram-positive cocci in clusters.
That is Staph aureus, and that is a different beast entirely. That is an immediate surgical emergency. The hallmark of an acute joint infection is pain out of proportion to what you'd expect post-operatively, coupled with systemic signs. For the exam, the correct management answer is never wait and see, and it is never just prescribe a course of oral antibiotics.
What is the correct answer?
The correct exam answer is prompt, immediate return to the operating theater for surgical debridement and thorough lavage, washing out the joint with liters of fluid, while taking multiple fresh intraoperative cultures before starting broad-spectrum IV antibiotics.
Fast and surgically aggressive for the acute staph infection. Slow and patient 14-day cultures for the indolent C. acnes. Okay, 2 final quick hits before our lightning round wrap-up. Osteonecrosis and the beach chair position. First, what causes the humeral head's interosseous blood supply to die?
A vascular necrosis, or osteonecrosis, means the bone is literally starving to death. The absolute #1 non-traumatic cause of humeral head osteonecrosis is the systemic use of corticosteroids.
Second time on that specific trigger. The top cause of humeral head osteonecrosis is corticosteroids. Why steroids? What is the pathophysiological mechanism there?
The exact mechanism is still debated, but the leading theory is that high doses of steroids cause fat hypertrophy in the marrow space and increase circulating lipids, leading to microscopic fat emboli that lodge in the tiny terminal intraosseous capillaries of the humeral head. This causes microvascular ischemia, and the subchondral bone dies and eventually collapses.
Oh, wow.
Other causes include alcohol abuse, hemoglobinopathies like sickle cell disease and Gaucher's disease. But steroids like high-dose prednisone for asthma or rheumatological conditions are always at the top of the list.
And finally, a surgical positioning pearl. When we do shoulder surgery, we don't lay the patient flat. We often sit the anesthetized patient completely upright in what's called the beach chair position. What is the hidden physiological risk of sitting someone up like that while they are asleep?
It comes down to the physics of a hydrostatic column. When you sit an anesthetized patient upright, gravity pulls their blood volume down into their legs and abdomen. Because they are under general anesthesia, their normal sympathetic reflexes to vasoconstrict and maintain blood pressure are blunted. This risks profound cerebral hypoperfusion, a lack of adequate blood flow and oxygen pushing up against gravity to the brain.
That sounds dangerous.
It is. The classic exam presentation for this complication is the patient waking up in recovery with a very specific nerve deficit, a sixth cranial nerve palsy.
Twice for the road to lock it in. Beach chair position hypoperfusion causes a sixth cranial nerve palsy, which is also known as an abducens nerve palsy. Why the sixth cranial nerve? Why not the optic nerve or the facial nerve?
It's an anatomical vulnerability. The abducens nerve has the longest, most tortuous intracranial cords of all the cranial nerves. Because of its long path along the base of the skull, it is highly sensitive to drops in cerebral perfusion pressure and the subsequent microscopic shifts of the brainstem. It controls the lateral rectus muscle of the eye, so the patient will wake up unable to turn their affected eye outward laterally.
So they will complain of double vision and their eye will be looking inward.
Exactly. The core management takeaway for the surgeon and the anesthesiologist is that you must manage the blood pressure extremely carefully. You have to monitor the mean arterial pressure calculated at the level of the brain, usually at the external auditory meatus, not just rely on the blood pressure cuff down on the patient's arm, which will read artificially high because of gravity.
If you only remember one thing for this final section, a preganglionic plexus injury with a flail arm is a strict contraindication to arthroplasty. Cutibacterium acnes requires you to hold cultures for 14 days because it is uniquely indolent. And systemic corticosteroids are the absolute top cause of humeral head osteonecrosis.
We made it through the heavy lifting. All the major principles are on the board.
Which means it is time for the final sprint to the finish line, the final lightning round. We do this to ensure rapid recall for the multiple choice section. I'm going to file the clinical prompt, and you fire the answer instantly with precision. Listeners, try to beat the expert to the punch. Say it out loud in your car. Here we go. The ultimate deciding question for choosing anatomic versus reverse.
Is the rotator cuff intact? Intact equals anatomic, deficient equals reverse.
The most common anatomic TSA complication and cause of revision.
Glenoid component loosening, primarily driven by the Walch B2 morphology.
Subscapularis repair failure causes what clinical presentation?
Anterior instability and massively increased passive external rotation.
Name the 3 danger structures in the delta pectoral approach.
Arcuate artery with the biceps, axillary nerve at the inferior subscapularis, and musculocutaneous nerve with conjoint tendon retraction.
What are the fundamental biomechanics of the reverse TSA?
It medializes and distalizes the center of rotation to give the deltoid a mechanical lever advantage.
What is the surgical fix for scapular notching?
Inferior base plate placement with an inferior tilt.
When is an iatrogenic humeral fracture most likely during a reverse procedure?
During powered reaming of the shaft while the assistant grips the arm too tightly.
What is the strict neurological contraindication to any shoulder replacement?
A preganglionic brachial plexus injury causing a flail arm.
Profound difficulty elevating the arm after a trauma hemiarthroplasty implies what error?
Humeral shortening during bone resection, causing the deltoid to go slack.
The shoulder-specific, indolent, infective organism.
Cutibacterium acnes, and you must hold the lab cultures for 14 days.
Nailed it perfectly. So let's take a breath and bring this all back together for a final thought. We've thrown a massive amount of anatomy, engineering, and biomechanics at the listener over the last hour. But when you step back from the textbook and look at it from a high philosophical level, what's the real lesson here for a surgeon?
It's truly fascinating. If you connect all the dots we've discussed today, every single failure mode essentially points back to one profound lesson. The long-term success of the artificial parts you put in depends entirely on respecting the natural biological anatomy you didn't replace.
Wow, yeah.
You can put in a perfect $1,000,000 metal joint, but if you don't meticulously repair and respect the subscapularis tendon you cut, the joint will immediately dislocate out the front. If you don't respect the deficient remaining bone stock of a Walch B2 glenoid, the plastic socket will rock loose in 5 years. If you don't perfectly tension the natural deltoid motor when placing a reverse, the arm simply won't lift.
It really makes you ponder where the field of orthopedics goes from here. We spend so much time focusing on the implants. But future advancements in shoulder arthroplasty probably aren't just going to be about inventing better titanium alloys or harder cross-linked plastics. It's going to be about designing smarter, more anatomically forgiving implants. Implants that demand less surgical sacrifice from the shoulder's natural guardians. Because right now, replacing the shoulder really is like trying to balance that heavy bowling ball on a tilting golf tee using frayed elastic bands. We are just trying to swap out the broken D without snapping the rest of the bands.
That is exactly the operative challenge. And mastering how those biological bands and that artificial T interact is exactly what will get you through the FRCS exam and, much more importantly, safely through your surgeries for the rest of your career.
Well said. Next time on our FRCS Revision series, we are moving outward from the joint to the wider shoulder girdle. We will be tackling the scapula itself, the acromioclavicular and sternoclavicular joints, and diving deep into the nerve entrapment syndromes. Everything from suprascapular nerve entrapment at the notch to the exact muscular failures that cause scapular winging. Best of luck with your studies. Keep reviewing these concepts in your head when you aren't driving, and have a very safe commute.